we tend to collapse several very different relationships into the word partnership. And on one hand, you have a social worker that sends them referrals and knows the name and phone number probably by heart. And then another is having a guaranteed capacity and exchanging data and paying for services and holding an organization accountable for resolving something that affects care. And those are entirely different dynamics. And choosing the wrong level of relationship can create a lot of confusion, a lot of struggle, a lot of cost on both sides. So I'm going to walk you through two Buddhist medicine experiences that I had this week. I'm going to use Feeding America's operating logic alongside my own procurement framework to show you what I was looking for. And then I'm going to answer the question I think that really matters is when is a referral enough and when does a problem justify a real partnership? So I went to the Joy Bus expecting the kitchen to be the most interesting part. By the way, I had the yogurt panna cotta at the diner area, and that was great. And I mention that because I'm no food critic. I'm not trying to be Anthony Bourdain here, but as many have said, that there is a direct connection between palatability and a intervention working the way that it's supposed to. But the interesting part is everything that surrounds the food. Joybus serves people with a cancer diagnosis and their caregivers. They receive referrals from major Arizona healthcare organizations that move through Salesforce. And I asked them to walk me through what happens next. I learned that they triage someone beginning treatment after losing 30 pounds is different from someone who has more support and less immediate nutrition risk. And so they make sure that they triage appropriately. And they told me that referrals can be accepted the same day, but because their delivery schedule closes early in the week, service can often begin within about a week. The food then goes out every week. And they described 3 entrees, 2 sides, a breakfast, and 4 snacks with quantities intended to provide a substantial share of the food that people need. They have a contracted RDN support and the University of Arizona dietetic students involved in calories and ingredients. They don't simply close the case after 4 weeks. Participants are reassessed every 6 months and can remain on the program while they still haven't returned to normal activities of daily living. So already I was looking at something much more structured than simply patient has a food program and then the social worker gives a patient a phone number. I wanted to share this whiteboard with you that they have at the very front. It shows 110,301 meals served since day one. For just 2026, that's 300 people, so 42,000 meals and 277 active volunteers, 9,000 volunteer hours. Those are some really impressive community impact numbers, but they don't quite tell me yet whether the organization can produce activity. So the volunteers here are interesting to me because they repeatedly enter the homes of people undergoing cancer treatment. And they've even built out a community support guide around that contact. So the transportation, financial assistance, insurance, emotional support, children and families, household needs, even pet care. They have this trusted last mile that's going into patients' homes and ensuring that there's continuity with these social support aspects. A locally embedded organization can see whether the care plan is actually livable once the patient leaves. So can they shop? Can they cook? Are they eating? Is their caregiver overwhelmed? Did the transportation fall apart? And human contact isn't automatically healthcare infrastructure, but if healthcare wants to purchase that capability, then someone needs to define what gets observed and what escalated and who receives it and how quickly they respond and who owns that resolution and what gets documented. So there's a big caveat around this, but otherwise is valuable community support, but not quite yet a managed healthcare pathway. Then this afternoon, Modify Health sent me this package. We can see here it says perishable, please refrigerate. So refrigeration is required. This is a pretty hefty box, pretty considerable size. And it says Modify Health right here on the side, so you know who it's coming from. So let's see what's in it. This is what it looks like when you open it. There's a label here that says exactly what's in it. It says total quantity and the number of ice gels in this box. It looks like 5 meals and this nice card. Nice little note. Then welcome to Modify Health family. There's refrigeration, unpacking, and heating instructions included. It says when you first open your delivery, the meal should be cold to the touch, and they are. This package is still pretty cool, which is impressive because we're in the middle of Phoenix summer heat here. And this was sitting out on my porch for about an hour before I went and got it. Meals can be heated in a microwave or oven, and instructions on how to select meals for future orders. There's one ice pack. And here we have our paprika salmon with herb roasted potatoes and green beans. Mahi mahi with roasted potatoes and herb green beans, Greek chicken and rice, garlic roasted chicken with sour cream and onion mashed potatoes, braised beef with brown butter mashed sweet potatoes and herbed green beans, and about 5 ice packs. I'm going to put these in the refrigerator. There's also a QR code to scan and rate your meal. So Modify Health is much closer to what I would call a healthcare native nutrition vendor. Its public model combines condition-specific prepared meals with dietitian support, remote monitoring, and patient engagement. It serves consumers, employers, health plans, providers, and Medicaid-related programs. Its strongest public clinical differentiation is GI care, and it also has third-party validated cardiometabolic outcomes. Its peer group also looks a little different. You take Food Smart, which is a bit stronger on telenutrition, benefits management, and publicly documented economic evidence, or something like Season Health, which is more platform and integration oriented. Nourished RX combines a food network, platform, and care model. Mom's Meals has enormous national meal operating breadth. And FarmBox RX is more produce/grocery engagement oriented. While JoyBus and Modify Health both put food in someone's home, they're not necessarily the same capability. And I'm not trying to say which one is better. Instead, we want to focus on what problem I'm actually trying to solve. So if I'm a national health plan with 5,000 clinically defined members spread across different states, then I need a standardized nutrition intervention delivered consistently. A healthcare native vendor like Modify Health will make more intuitive sense there because I'm buying standardization, geographic reach, condition-specific nutrition, dietitian support, and a repeatable operating model, and potentially an easier enterprise implementation. My contracting model might be a defined episode or a per engaged member structure or a service bundle with meals, nutrition support, engagement, and reporting. I would still diligence the data, security, integration, and outcomes methodology. My existing public source assessment of Modify Health found meaningful strengths, but not quite enough public evidence to recommend a large at-risk deployment without deeper diligence. Now change the problem. If I'm an Arizona oncology system and my teams repeatedly encounter patients who can't maintain adequate nutrition during treatment, either because some are food insecure, some can't stand long enough to cook, some have overwhelmed caregivers, Some need transportation or financial assistance. Now I need someone who knows this local oncology ecosystem and can respond quickly and see what is happening at home. Now JoyBus becomes much more interesting because the local embeddedness is part of the capability that I'm trying to purchase. I probably wouldn't initially ask JoyBus to become a miniature health system. I'd wrap the healthcare infrastructure around what they're already good at. So if I'm a healthcare system, I would still want to own the clinical eligibility, medical appropriateness, claims, clinical outcomes, financial attribution, and potentially billing, and let the vendor own local intake, food, delivery, home contact, navigation, service documentation, and barrier escalation. And so that's a much different contract. There's actually a third option here, and this is the decision rule that I think a lot of healthcare needs. Use referral when you mainly need to make a resource available, when that need isn't necessarily time sensitive and you don't need confirmation that the service happened. If the buyer doesn't retain meaningful financial or quality exposure, if the volume is low and the administrative burden of contracting would exceed the expected value. There's nothing wrong with a referral relationship. In cases where you need more, like reliable acceptance, priority access, known turnaround times, confirmation of service, escalation, resolution data, repeated local capacity, then you would need a wrap. You would need a formalized, locally embedded CBO. But that doesn't mean that the community organization has to carry the entire administrative stack, especially if they aren't ready to. So JoyBus is the kind of organization that I would evaluate for that kind of architecture. When you need a standardized product across meaningful volume or geography and want more of the service, clinical, and administrative infrastructure bundled into the vendor relationship, then you would look at buying. So you would want to use a healthcare native vendor for that, and Modify Health is much closer to this architecture. So it's not a decision of local nonprofit versus national vendor. It's refer, wrap, buy, and base that upon how much control that the problem actually requires. Now, I want to give you some examples on how other buyers are already using all three architectures. First, we'll look at community servings in Massachusetts. And this is what a mature local clinical CBO can eventually look like. Community servings delivered more than 1.2 million meals to 6,866 people in 2024. It had contracts with at least 10 Mass Health ACOs and broader relationships spanning Medicaid, Medicare, Medicare Advantage, commercial plans, provider networks, and home hospital. Its model is highly clinical, multiple RDNs, 16 medically tailored diets, and individualized plans that can combine up to 3 dietary tracks. And it has unusually strong evidence. Vendor-linked research includes a randomized diabetes study and a large claims-based analysis associating medically tailored meals with fewer hospital and skilled nursing admissions and lower monthly medical spending. That's a mature contracted CBO model. Central Texas Food Bank has a huge regional food distribution backbone, but its healthcare partnerships increasingly sit on top of it. With Central Health, it launched a year-long medically tailored meal pilot for up to 600 low-income patients. So providers refer, case managers and community health workers help support the pathway. Patients receive 7 frozen meals per week for up to 8 weeks, or 14 meals per week for patients with chronic conditions and malnutrition. So my own procurement analysis classified Central Texas Food Bank as Tier 2. That's a credible healthcare partner but still better suited in the near term to operating behind a healthcare wrapper rather than pretending that it already has a complete payer grade reimbursement stack. And that's not a weakness, that's just role clarity. The food bank can remain the product engine while the healthcare carries more of the clinical and administrative infrastructure. Then Massachusetts shows us what happens when the entire market matures. Mass Health started flexible services nutrition as a pilot in 2020. By January 2025, it had moved into standardized HRSN supplemental services, and now there are standardized eligibility criteria with contracts, service manuals, billing codes, rate ceilings, documentation requirements, ACO responsibilities, and provider responsibilities. About 22,000 members received HRSN nutrition and housing supports in 2025, and the major statewide evaluation included 20,000 nutrition participants across 17 ACOs and found lower hospitalizations and ED use. A related synthesis in my source work reports approximately 23 fewer hospitalization in 13% fewer ED visits among participants versus non-participants over 2020 and 2023, with the important caveat that this is an ecosystem level mass health result and not an outcome attributable to any single CBO. But it's still worth mentioning because that's what happens when partnership becomes market infrastructure. And then you have infrastructure models like Instacart Health. And so if my problem isn't medically tailored prepared meals at all, maybe I need member-directed grocery benefits or provider-directed baskets or broad retail access or flexible food stipends, then Instacart may make much more sense. Its Fresh Funds, Care Carts, and other models support several deployment architectures, and its Medicaid pathway has moved toward claim submission through its Adonis partnership. So again, different problem, different architecture. Now, I don't know Joybus's contract price. I'm not going to invent one. And Modify Health's publicly visible consumer pricing is not necessarily what a health plan would negotiate. So I'm not going to pretend retail price equals enterprise price either. Instead, I would model these using real healthcare purchasing benchmarks and published evidence, and then replace the assumptions with negotiated numbers during procurement. Mass Health gives us one particularly useful benchmark because it's turned nutrition into an actual reimbursable service architecture. Its HRSN program defines eligible populations, service units, duration, provider requirements, and fee schedule logic. Medically tailored meals can be delivered up to 3 times daily, 7 days per week, with a minimum episode requirements under the current service model. What I've found is that Medicaid nutrition supports can plausibly become net positive when targeted to high need populations, priced roughly in the $8 to $12 per meal range and delivered for controlled durations. But economics change substantially by reimbursement lane and adherence, because there is no universal food as medicine ROI. My own 2026 modeling found positive modeled PMPM under several targeted Medicaid nutrition scenarios, while broad Medicare Advantage food allowances and short-term post-discharge meal scenarios were not automatically cost neutral from medical savings alone. And that's exactly why vendor selection has to follow the financial problem. Imagine I have a geographically distributed high-risk population with a diet-sensitive condition. I can then define the eligible cohort, the number of meals, the episode duration, the nutrition assessment, the engagement requirements, and the enterprise service price. And then the financial question becomes, does the measured improvement in the outcome I targeted create enough buyer retained value to exceed the full program cost? And if I'm buying across multiple markets, then the standardization itself has value because I don't have to construct a new local operating relationship in every single county. In the second model with a CBO like purchase, the economics are different. So the food is still a cost here, but I'm potentially buying more than food. I'm buying rapid local response, home contact, navigation, social barrier detection, and potentially relief of work that my clinical teams are currently doing themselves. I would model food plus production plus delivery plus RDM plus navigation plus data/reporting plus a healthcare wrapper against the specific buyer retained failure costs that I believe this pathway can change. And those can include clinical team time spent repeatedly resolving the same barriers, treatment disruption, if that is the prospectively selected mechanism, acute utilization only when there is a defensible causal pathway, quality or other contract exposure where relevant, and I'd shadow price the volunteer labor. So JoyBus had 277 active volunteers and 9,000 volunteer hours on board when I visited, and that's extraordinary community leverage, but it's not permission to enter $0 delivery labor into a scale model. So if the model expands, then I need to know what happens if volunteer capacity doesn't expand with it. And that's how you can get honest about the economics. So now we get into the most important question, why partner at all? Because why not just keep letting your social workers refer people? A referral says that you found a problem and showed the patient where help might exist, but a managed partnership can say that you found the problem, someone accepted that responsibility, service started, it continued, the failures were surfaced, additional barriers were escalated, and we know what happened. And so eventually we can determine whether resolving the barrier changed the outcome that we actually cared about. If you don't need that level of control, then it doesn't make sense to pay for it. But if you do need it, then continuing to rely upon referral isn't necessarily free. And that's where I think healthcare often uses the wrong denominator here, is that the status quo actually does have a cost. So the choice is rarely spend X dollars on social care versus spend zero, because you're already operating a pathway. Maybe social workers repeatedly make referrals, or other staff solve your food problems. Maybe care managers chase the same unresolved needs, or maybe treatment becomes harder to execute. Maybe patients show up downstream. Maybe community benefit dollars still fill fragments of the same gap. And some of those costs belong to healthcare, some don't, but don't inflate them. Calculate the ones that you actually retain, because the relevant comparison is, what does it actually cost us to change this failure mode, as opposed to what are we actually spending to live with it. The model that I would bring in isn't we should start investing in food and medicine. It's we have X problem in Y population and believe Z social barrier contributes to it. So we currently retain a financial or operational exposure because the problem remains unsolved, and there's an existing capacity in our market capable of addressing it. I want to determine whether referral is sufficient or whether we need a full managed pathway. And if you need the managed pathway, then only buy enough of it to determine whether that hypothesis is true. So define the population, define the intervention, cap enrollment, cap duration, cap total exposure, predefine the outcome, predefine the evaluation date, and predefine who earns expansion. Because the first contract has two deliverables, it's service and evidence. Now we come to the bigger opportunity here, and that's food as medicine is just an unusually visible example, because this same architecture applies to many social care supports, whether that's transportation, housing, navigation, home remediation, caregiver support, legal services, community health workers. Healthcare doesn't necessarily need to build every one of these capabilities, but it doesn't necessarily need to replace every local organization with a national platform. There are three legitimate choices, and when access to a resource is enough, then you can go ahead and just refer out. When an existing community capacity is valuable, but healthcare needs reliability, data, and accountability around it, then we wrap. And then when a healthcare native vendor can deliver the standardized capability you need at the required scale, then it makes more sense to buy. And sometimes eventually the state or the payer can turn the whole thing into infrastructure. If this helped you in some way, I just have one small ask, and that's that you share this with someone that you think can also benefit from this information. Thank you so much for subscribing and for watching.